Alrighty, so yeah, why don't we jump in? We're going to be talking about mold and mycotoxicity. I'm first and foremost grateful to the organizers for putting this event together. It's been fantastic. I am very grateful for the opportunity to be here and to join you guys with this presentation, and it's just been great to connect with everyone that's here. I certainly missed in-person conferences through COVID, and it's nice to be back into that a little bit more regularly. I'm also grateful to the previous speakers. They've covered mold a lot. I feel like I maybe don't have to do too much here, but it is a big topic. It's very relevant within the world of Lyme and co-infections, tick-borne illness, and just out of curiosity, who ends up testing for Lyme, treating a lot of Lyme, at least as far as they, subjectively feel. So that's helpful to know. And so, I mean, with a topic like this, as is the case for anything that we've covered so far, where looking at a situation, actually, Dr. Farrow did a great job of contrasting, or comparing rather, the symptoms of chronic Lyme, or Lyme and persistent Lyme with that of mycotoxin illness, and there's a lot of overlap. And so when you are dealing with someone who has a complex chronic illness, this is often something that we keep on our radar. And so that's one of the prime reasons we want to be cognizant of this. Another thing is, if it's often said, if the patient's not getting better, think mold. And that could be said of any environmental toxicant or trigger. But the reality is, if mold is present, it's something that needs to be triaged quite highly. It can really stand in the way of us achieving optimal outcomes when it comes to our targeted tick-borne illness treatments. And so this is something that warrants a lot of attention and can often fly under the radar. As far as disclosures go, in terms of relationships with the financial interest, I am a medical consultant for VitaAid Professional Therapeutics. Nothing in relation to that relationship is going to be reflected in this talk, and I have no commercial interest with any of the labs or other kind of organizations that come up during this discussion. Just very briefly, I'm a naturopathic doctor. I practice just north of Toronto in Barrie. A little bit worried about the snow for the drive home, but I deal with complex chronic illness, and obviously mold and mycotoxicity falls under that umbrella. We're going to go over differerences between mold toxicity, and that's exclusively what we're talking about, but we want to distinguish between that, mold allergy and mold illness. We'll go into pathophys, look at signs and symptoms, talk about testing. That comes up a lot with the consultations I have with colleagues. We'll look at testing body burden. We'll look at testing the space that the person is living in, and Dr. Farrow also touched on this. It's not always the home. Is it the car? Is it the office? And then we'll talk about some treatment strategies. Obviously, there are folks here that are actively engaged in this world. There are going to be folks that aren't, and so there's a lot to cover. I'll do my best to ensure there's a high-level overview to give us all a foundation and anchor point, but at the same time, if there's anything that we can dive into in greater detail, particularly for those folks that are doing a lot of this work, we will try to do that as well. So in terms of overview, the reality is we're constantly exposed to molds. In the spring and the fall, there's going to be a lot of tree and soil mold exposure. What we're particularly focused on here would be those molds that produce mycotoxins that are harmful to humans. We're often focusing on those molds that are associated with water damaged spaces, flooding. That's come up multiple times today as well. But recognizing that not all molds are toxic, nor do they all produce toxins that are harmful to humans. We're focused in on mycotoxins today, but bear in mind that there are a host of other factors that drive inflammatory burden within the body, VOCs, et cetera, driving direct infection, toxicity, allergy, irritant effect, and systemic inflammation. So just be mindful, we're focused on mycotoxins today, but there are other factors that are going to be immune insults that we need to keep on our radar. Individual responses vary. You're going to have a lot of patients who are the canary in the coal mine. Their family members are not struggling the way they are. That can make it very difficult because remediations are expensive, and that can lead to very significant conflicts within the household. But the bottom line, and Dr. Cook did a great job of elucidating some of the genetic factors that can be relevant here. Dr. Farrow went into the bucket, right? All of the different toxicant factors and other elements that fill up the person's bucket. But we will see a lot of variability with respect to the response. The symptoms are nonspecific, they're vague, they mimic Lyme and co-infection, they look like what someone is generally experiencing with ME, CFS, fibro, multiple chemical sensitivity or general environmental intolerance, as well as many neurological conditions. In addition to the immune-mediated insult that the mycotoxins drive themselves, there's also a mechanism by which they can trigger secondary issues, mast cell activation disorders, limbic system dysfunction, and that's been touched on a number of times this weekend as well as pathogen reactivation. This is not well studied, and that makes it challenging because it's not universally accepted within the medical community that mycotoxin illness is a thing. Thankfully, there is growing data and a growing understanding, but nonetheless, we don't have clear epidemiological data. I remember Neil Nathan at one point saying there may be 10 million folks in the States, dealing with mycotoxin illness, and maybe more, maybe less, it's hard to say, but those of us that operate within these kinds of practice, we will tend to see a disproportionately high amount of these folks because they are not well managed and in the conventional system. As I mentioned before, one of the key reasons we even want to go through this, failing to effectively address mycotoxicity, if applicable, will negatively impact the ability to effectively treat Lyme co-infections with the targeted strategies that you are trying to engage in. If someone's not getting better, think mold, and it does typically need to be triaged quite highly, dealt with early on in the protocol. Very quickly, just looking at the distinction between mycotoxin illness, allergy, and mycoses, we're looking at the immune response to mycotoxin exposure specifically, not what's kind of considered generally within the medical community, which is going to be more along the lines of a mold allergy, the IgE hypersensitivity reaction to mold antigens. We're looking at the mycotoxin, the immune response to mycotoxins, and this is distinct from a frank, direct fungal infection. We're not thinking about that in the context of what we're speaking about today. In terms of the pathophysiology, when it comes to mycotoxins themselves, they're secondary metabolites of mold compounds. They're driving immune activation within the body via various mechanisms. There are several molds that produce toxins that are harmful to humans. They're listed here. Certain ones are particularly relevant within the context of water-damaged spaces, Aspergillus, Penicillium, Stachybotrys, that's black mold. But we do want to be mindful of kind of the broader cascade of molds that can be problematic here. In terms of exposure, dermal, inhalation, ingestion routes are common. As I mentioned, it's very common, particularly in a place like Ontario, for us to be exposed to a number of molds via outdoor mold exposure. In terms of inhalation, though, when we are thinking about the burden associated with molds producing mycotoxins that are harmful to humans within a water-damaged building space, flooding, those kinds of things, what we end up dealing with is a high burden, a persistent burden, and when we couple that with genetic factors or just total body burden associated with toxin load, we can start to see some big issues manifest. We're going to be consuming molds through the ingestion route with grains and fruits and veggies. That's not uncommon, and you'll see that pop up on tests. But the volume is low, the burden may not be as significant. We're really thinking about what's happening from that inhalation route. And then we are, in addition to the mycotoxin, immune-mediated mycotoxin burden associated with that, there is colonization, and Dr. Cook touched on that as well earlier. One thing to be mindful of, the cribriform plate is particularly porous at the ethmoid sinus, and you can get translocation of these mycotoxins through that medium there. And these mycotoxins like to propagate along nerve pathways and can have fairly direct interaction with the central nervous system, which is not good for obvious reasons. Yeah. Brain fog is a big feature here. As I mentioned, what we're really focused in on are the water-damaged buildings, the flooding, and the molds associated with that burden. There are multiple ways in which the body is overwhelmed through mycotoxin exposure. Immune suppression, or more broadly, immune dysregulation, is going to be a big one. I bolded the first three because they are quite upstream in the downstream effects they have. the level of immune dysregulation is significant. The Th2 polarization that's induced by these insults can be profound for a lot of folks, and can limit the ability for us to get optimal outcomes when it comes to antimicrobial use because of the underlying immune dysregulation. Beyond that, you're getting a 1-2 punch with respect to glutathione depletion in addition to elevated oxidative stress. So it's kind of kicking you when you're down. And if someone has a glutathione SNP or a genetic SNP related to glutathione capacity, like myself, that can be problematic because now you're really getting kicked when you're down, salt in the wound kind of thing. Mitochondrial dysfunction is going to be another primary mechanism by which pathophysiology starts to become problematic and overflow for a patient. There are other ways in which we will see problems manifest, DNA and RNA disruption, direct organ damage, neurotoxicity. The bottom line is we're seeing a multi-mechanistic immune-mediated inflammatory burden causing this immune dysregulation, and we see breakdowns across various systems, and you'll see how that plays out when it comes to the treatment strategy. This is super small print, but it's in your slides. US Biotech has a nice visual that demonstrates maybe I can do this, can I do that? Yeah. Different molds and the associated mycotoxins. And that just helps to give you a quick reference when it comes to some of those molds, Aspergillus, Penicillium, et cetera, that are associated with water damaged spaces. And again, no affiliation with any of the labs that I'll be speaking to. In terms of health effects, that's even too small for me to see with my big old glasses. Hepatotoxicity, so the direct organ insult, hepatotoxicity, nephrotoxicity, neurotoxic. We're seeing carcinogenicity, which Dr. Adrian spoke to recently at the AMP, which unfortunately I didn't get a chance to sit in on. Genotoxic, immune suppressive. There's just a number of ways in which these mycotoxins can insult the body, and that gives you greater perspective as to why these symptoms are so multi-system and widespread and vague. In terms of symptomatology, there's nothing that's frankly like pathognomic here. There's no target lesion. There's not one thing we're looking for. There may be some smoking guns. Brain fog is going to be a big one, but who's not seeing brain fog flagged on every intake form coming into your office, irrespective of whether mold is present or not, simply because of the many ways that can manifest in complex chronic illness. But folks may complain of ice pick or lightning bolt type pain. We see this phenomenon of static shocks manifest, lots of brain fog as well, but you can see it can be quite widespread with respect to the clinical presentation. If there's colonization, we might see some of the allergic kind of propensity manifesting within the respiratory tract. You might see some GI issues as well, but it can really be a lot of things. So someone comes into your practice, they present with symptoms consistent with Lyme and tick-borne illness. We're mindful that there could be some overlap with respect to mold and mycotoxicity. How do we go about assessing for that? Of course, it starts with your intake. You're asking about visible mold. You're asking about musty odor in any spaces, any flooding or water damage. And I still, to this day, don't understand, and this is not judgmental, I just struggle with it, how patients don't necessarily connect all of the flooding that happens in their home and me asking that question. I have to ask it about 4, 5, 6 times before there's like, oh, well, yeah, no, that floods. But it's like, not but. Let's pause there and let's work with that for a little bit. But you really have to pry, and you have to go back, and you have to ask in different ways about flooding and water damage. I had a patient recently who gets a flood every spring, and that's just the norm for his basement. And that did not register as being relevant to the questioning I was trying to direct, and so you just need to poke and prod and keep poking and prodding. Do they feel unwell in certain spaces? Sometimes we get folks to leave that space, and hopefully they're not going to another exposure site, but we get them out of the home 1-2 weeks, see how they do, and that can sometimes provide some insight. If you're not sure where to start, I've ended up just incorporating it into my intake form, but the NAEM, the National Association of Environmental Medicine, has their EHQ, the Environmental Health Questionnaire, and that does a really good job. You're not going to be able to read all that, but that does a really good job of just laying out questions that are relevant here to screening for mold exposure, in addition to VOCs and pesticides and everything else that they have in this multi-page questionnaire. But this is a helpful tool for anyone that's just not sure on what to ask. So you've questioned around it, your spidey senses are tingling, you believe that mycotoxin burden might be a factor in this case. So we move into testing, and body burden is often where we start. Who's doing urinary mycotoxin testing at this point? Is anyone doing the serum testing? All right, one person. And I'm saying all right just because I'm intrigued. I'm not using it in my practice yet. I'm an observer, not necessarily an early adopter that way, but typically we are looking at urinary mycotoxin testing, looking for levels of mycotoxins in the urine, often or typically using mass spec or ELISA. In terms of testing, there are a few things we'll want to consider with respect to PrEP. One is being mindful of use of binders if someone is already on it. We kind of want the enterohepatic recirculation to be able to achieve urinary output of these mycotoxins that would flag something if it is in fact relevant. So try to cut that out a few days before urine collection. Does anyone do provocation? Glutathione, saunas, sweating, all of the above, saunas. So this glutathione regimen can be pretty intense for some folks. I deal with folks that are highly sensitized, and so we tread cautiously, but the dosing and the duration mobilizes mycotoxins, it mobilizes other toxins. Not everyone, well, most people do not feel great doing this, but on day 7, we'll do the urine sample collection. Other times, sauna, sweating can be done. Doesn't have to be done too far in advance of sample collection, but that's another means by which we can try to provocate or mobilize these toxins. But even in the instant of provocation, it's not unusual to see folks with urinary levels that are low or normal. There was a patient actually that was co-managed. I was moving practices. I sent them to Dr. Bray and Dr. Elgaz at Enviromed, and her urinary mycotoxin test was nil. All of us were like, no, can't be. And her air sampling showed aspergillus levels beyond anything that had ever been seen. And so there are reasons folks might be holding on to those toxicants within fat-soluble tissue, in their neurological tissue. They may have impaired detox functionality, which Dr. Farrow and Dr. Cook have spoken to as well. So just be mindful. It needs to be a multimodal assessment, but the urinary mycotoxin test is certainly something that we typically keep on the radar. And I think this was brought up by Dr. Farrow, but you often, or it's not uncommon to see those urine mycotoxin levels rise as you go through the treatment process. I'll typically retest within 3 to 6 months, again at 12, but it's very variable. The needs may vary based on the patient. In terms of labs that represent the 2 forms of urine mycotoxin testing technology that I kind of spoke to, oftentimes we're looking at mass spec, liquid chromatography mass spec, as having an advantage, or at least a purported advantage, of having higher sensitivity. The argument in favor of ELISA is that it can identify mycotoxins that have been modified within the body that might be missed using the mass spec technology. And you'll notice that the lab that uses the ELISA has tests for slightly more markers. Someone like Neil Nathan, will mention that he, when possible, will run both the ELISA and the mass spec, and I think that came up yesterday, and it's not feasible for all patients. At the end of the day, and there were some preferences around mycotoxin testing that came up yesterday, and so certain individuals will align more so with different tests based on their clinical experience, but the bottom line is, we want to be able to look at this within the context of the bigger picture, what's happening from a clinical presentation, symptomatology perspective, and we do want to also be testing the space that we believe to be affected. I have not integrated serum testing into my practice, and what's interesting about this form of testing is it's not looking at mold antigen reactivity. We're looking at mycotoxin antibody response. Dr. Campbell has a ton of information online. He's very vocal about what he's doing in this space. Like I said, I just have not brought this into my practice. I know there are many individuals that have and speak highly of it. I'm curious to know if anyone is. I'd love to speak with you after maybe speak with you after the talk. But the argument in favor of that is higher specificity. I don't have the numbers. I feel like if Dr. Hawkins is watching, I might need to clean these slides up so we can actually do statistical analysis the next time I present. So in addition to looking for urinary mycotoxin levels, possibly serum testing, we are looking to see what is the kind of physiologic burden that that patient is facing. And you're going to be considering things along the lines of inflammation, immune, metabolic, nutritional workup to understand what that patient's fallout is. You may add to this list. This is just kind of an anchor point. I do tend to run quite a bit of an organic acid test. I like it as a high-level kind of overview with respect to functionally what are we seeing with respect to glutathione capacity, mitochondrial function, nutritional needs, yeast and bacterial, albeit limited, overgrowth, dysbiosis within the gut, colonization burden within the gut. Not a perfect test, nothing is, but it does help to kind of see how the genetics are interplaying with these environmental triggers in a way that we might be able to actionably intervene. MCAS workup, not sure, right? Is that going to change your treatment? How accessible is it? Whether it's consensus 1 or 2 criteria, are we actually flagging true positives here? So it's, I'll leave that to you. And as a naturopath in Ontario, it's not something that I'm running anyway. Shoemaker protocol, similarly, there are those that are very in favor of it, those that have maybe shifted away. I've put it in here for completeness sake. It's not something that I utilize or follow in my practice, partly because of accessing these labs, and I've just found other ways that I choose to work folks up and treat. But nonetheless, this is obviously something that's been had a very strong foothold within this space for a long time. In addition to assessing body burden, looking at urine mycotoxin testing, possibly serum, in addition to what's happening from a inflammatory, immune, metabolic perspective, it's worth being mindful, even if you're not the one doing this. You do want to connect with an inspector that does good work, a building biologist that does good work, but we still need to be cognizant of how we can help guide folks and interpret what's happening in terms of testing the air and surface samples. There are 2 ways in which we go about this. First would be visual or microscopic. Gravity plates are something that I use a lot with patients. They can access this directly from a lab out of Florida called Immunolytics. You can do just a visual inspection, though the goal would be to have it sent back to the lab for analysis. But those gravity plates are great. They're able to catch spores that are falling to the ground that aren't necessarily captured in air sampling. Swabs and tape plates also, or tape lifts also help to facilitate that, but you're typically working with an inspector for that. It can be, from an accessibility perspective, I have many patients that struggle financially, and we just try and work with what we can, and it's about $3 US per plate with Immunolytics, 36 when you are doing the analysis. But even if we're just starting with a visual inspection to see where we need to start testing or what we need to do, is it the home, is it the office, is it the car, whatnot, it can at least help direct our focus going forward and be more efficient if they're then engaging with an inspector or building biologist. And then if you are working with someone who's trained in the space, they will likely be doing some ERMI or HERTSMI testing, and Dr. Farrow kind of touched on this earlier. Small print, actually not too bad over there. This is from Immunolytics, and it's just a nice quick reference guide with respect to the different ways in which we might assess the living space or the spaces that the person might be exposed to. I think I meant to say this earlier, but portables, not good, right? So a lot of teachers, I treat a lot of teachers, and if they're in portables, this is just notorious. And the school system, at least here in Ontario, they do not remediate at all. Just cover it up. So anyway, this is just a nice breakdown with respect to different ways in which we can assess for external burden, environmental burden. So you have completed an intake that has flagged your suspicion with respect to mycotoxin burden. You've completed urinary mycotoxin testing. We've worked them up from a blood work perspective. Now we're looking at management. There are various different ways in which we can approach this. Most of them follow a flow chart similar to this. Depending on your preference, your style, you might modify the order, but this is typically how we would want to approach things. And first and foremost, it's remediate or relocate. And this is a really challenging discussion to have with patients. This is overwhelming. It's a tremendous financial strain. It strains relationships when you have one person that's doing very poorly, the canary in the coal mine, and you have a family member or family members that are doing just fine. But the bottom line is we need to seriously discuss how we can remediate, relocate, and in situations where that's not possible, I have many patients that are unable to do both. They're in rentals, they are financially strapped. We do the best we can to support. We create a sanctuary space within the home, try to protect that space, have them spend more time in that space, but you just do the best you can. But gold standard, we would need to remediate with someone who is savvy, not just a kind of standard remediation company, or relocate. Generally speaking, we need to keep relative humidity quite low, 35 to 40%, so that we don't want humidifiers used in the home centrally, at the very least. Being mindful of central and portable air purifiers. There's different perspectives on the utility of the portable air filters. I don't think they're the panacea that some folks make them out to be, but as part of a sanctuary making protocol, they might have some utility, particularly in a smaller space. And they also can capture VOCs and some of the other harmful substances. There are some individuals that don't really feel that the central air filters do a great job of capturing mycotoxins. There are others that do, but nonetheless, we want to try and ensure that that central system is as optimized as possible. Pulling carpets, cleaning porous materials that we can. We'll often use borax. There's argument that just good old soap and water, multiple washes might do the trick, but there are going to be a lot of porous materials and furniture and substances that we can't clean, right? Sofas and mattresses, books. People do not like getting rid of their books, but we have to have those discussions as well. Making sure that we're using a particularly effective or high efficiency particulate air filter. I tend to recommend Mealy, but I'm sure there are other options that are well adept in this space. And preventing flooding and water damage. If there's a recurrent issue like my dear patient who has the springtime flooding, that needs to be dealt with. That just can't be what it is. Not going to fly. Binders are more controversial than I ever thought they might be. I mean, I see a lot of utility for them in practice. I know practitioners who really don't like to utilize them in practice, but at the end of the day, if we can utilize something that is going to help prevent enterohepatic recirculation and foster elimination through the bowels, that is helpful, particularly if someone cannot get out of that exposed space. That can be really helpful to ensure that we're just trying to manage the total body burden. In terms of side effects or risks associated with it, we can see absorption of essential nutrients when we're using these agents, so just be mindful of that. Sometimes we have to add in some IVs or oral multi-minerals if we're using it for more than 1-2 months, etc. This is a visual from Mosaic that outlines different binders and their affinity for different mycotoxins. You know, if you're dealing with Aspergillus and you've got your OTA, you know, it's nice to see that there's a number that can be helpful there. I tend to use a lot of charcoal. I tend to use a lot of humic and fulvic acid. I tend to use a lot of probiotics, and then we'll cycle, and there may be times where we dance between many other options as well. In terms of probiotics, what's helpful here is you're not only getting there's multiple mechanisms by which probiotics work as binders, but you're also getting gut-specific support, you're getting immune modulation. At the very least, I get folks on a high-potency multi-strained probiotic that is heavily lactic acid bacteria-based, just to get broad coverage, and that's represented here. At the very least below that, we'll do Saccharomyces boulardii. It's antifungal, it's anti-biofilm, and it's a mild binder, 20 billion CFU daily. And Lactobacillus rhamnosus GG. Not only does it have these binding effects, but it helps to pull back on that aberrant Th2 polarization that we see represented in this demographic as well. In terms of a sample protocol, cholestyramine will be utilized. I don't use that in my practice. I don't have prescribing rights for it, and I just use other agents. But these are some of the things you might consider. We've done our best to remediate or relocate, or at least create a sanctuary. We've utilized binders in such a way that we can mitigate enterohepatic recirculation. Now we want to get into supporting detox and redox capacity. And so ultimately what we're trying to do, and this is piggybacking on a number of the talks that have kind of come before me, we're trying to just optimize, particularly phase 2 detox, getting these substances out of the body. And it's not just the mycotoxins, we're thinking of total toxin burden. One of the things that because I treat folks that are highly sensitive, does anyone use glutathione and get herxes in patients? It happens, right? One of the things that we want to be mindful of is kind of the hierarchy or the ladder we need to follow when it comes to utilizing glutathione with certain patients that are highly sensitive. And this is shout out to Dr. Paul Anderson. He's a naturopathic physician out of Arizona. He's very heavily focused on ensuring we're supporting the foundational tocopherol fat-soluble pathway and ascorbic water-soluble pathways. And I've seen this support patients time and time again. So if we can get the natural mixed tocopherols in, if we can get ascorbic acid in at doses that are appropriate for that patient, ensuring that those two wheels are turning effectively, then we can start to go in with NAC, a precursor to glutathione. We can utilize cofactors like selenium. We can use things like molybdenum, which can help stabilize in these situations as well. And then move in with glutathione. So if you have someone that's just completely intolerant to glutathione, but you recognize its utility based on their genetic profile, based on their symptomatology and clinical situation, just be mindful of trying to support these various steps. And it might look something like this. Milk thistle, ALA, gotu kola, they're all helping to recycle glutathione. So it's one thing to kind of get it into the system, ideally IV, oral if they can, manage the taste. And there are some products that are not horrible, but just trying to make sure we're doing this in a multifactorial way. Personally, I feel that this is underappreciated, but I'm so encouraged that every talk kind of went into immune modulation. Fantastic, because I'm an end-of-the-road doc. I see a lot of folks that have worked with a number of practitioners similar to your practice, and one of the things I find in terms of why they may not have achieved the outcomes we're looking for them to achieve and hoping for them is the immune modulation piece hasn't been adequately addressed. I'm going to shout out Dr. Sam Yannick, who is involved with the Cogence Immunology Program, fantastic clinical immunology program. I have no affiliation with them. This is a highly simplified view of what he has built into this monster project and his team. But if we can, at the very least, think about 3 primary targets. Supporting Th1 response, and Dr. Cook has talked about this as well. The nice thing about this is if we're using herbal agents, which obviously as a naturopath I tend to gravitate towards anyway, you're able to capitalize on multiple targets. So single input, multiple targets, something like Chinese skullcap. You're modulating and supporting Th1, which is a master switch, which helps to pull back on Th2 overdrive and Th17 autoimmune hyperactivity or hyperresponsiveness. We're using a lot of Chinese skullcap with our Lyme and co-infection patients anyway from an immune modulation perspective. So that lends itself well to kind of a 2 birds scenario. Berberine, we're generally familiar with, antidysbiotic, including antifungal. It reduces inflammation at the gut level. It helps with insulin sensitization and glucose control. There was something else, but I can't remember, but it does a lot of things. Ginger is going to be anti-inflammatory. Sulforaphane has come up as well. If we're dealing with someone with a GSD SNP or an SOD SNP, we're mindful of utility there as well. Beyond that, we're looking at promoting T regulator cell activity. This is fairly, common ground. I tend to use a high DHA omega-3 with respect to the neurocognitive support, neuroinflammatory support, and its effect as a pro-resolvin mediator. Vitamin D came up already. It's not as simple as just utilizing Health Canada guidelines. We need to test. We need to, if possible, assess genomics to be able to understand how someone might respond to that intervention. And we need to optimize. It's not enough just to get them above the 75 nanomoles. Beyond that, because of the direct immune-mediated inflammatory response, in addition to the MCAD type activity and just general Th2 polarization that mycotoxin burden induces, These are some agents you might consider. Astragalus is great with respect to this outcome, but also increasing natural killer cell activity. If you have a patient who has EBV reactivation, this is a great kind of prophylactic tool that can be used in that setting. NAC is great if we're thinking about that redox support. There's another way in which it'll influence positive outcomes in this case. Perilla, quercetin, and just be mindful, and this is a standard issue for any case that we're working up or managing. If there's gut epithelial inflammation, we're not pulling back on that Th2 dominance, right? So that just, it generally is, but it has to be part of what we're doing here. I don't prescribe LDN, I refer out for it, but that's obviously something that can be utilized here within the context of immune modulation from a drug therapy perspective. So again, just a general kind of sample consideration here with agents that might have multi-mechanistic effect within the body. Be mindful of berberine with respect to GI side effects, and I have not gone through any drug-herb interactions. That would be something that would need to be screened for, particularly with herbs. In terms of eradicating mold colonization, there was a long time in my practice where I was like, I'm not sure if this is really happening, but no, I recognize my short-sightedness. And, you know, in a conventional medical setting, if you're not seeing, you know, manifestations on imaging, they may not, you know, really flag for this. But this is something that's very relevant to these folks, given the ongoing burden with respect to the volume and the kinds of molds that we're seeing in these water-damaged spaces. I don't utilize the drug therapy options in practice, but they're here, and I'm going to shovel questions to Dr. Cook if you do have any regarding drug therapy. I use a lot of herbals, and my bias towards that is they are innately biofilm disrupting in nature. They can be quite potent. I tend to use a nasal spray that is saline-based. It has xylitol, EDTA, grapefruit seed extract, and iodine. It's compounded at a pharmacy just a little farther uptown from here. But otherwise, there are a ton of options that can be utilized. There's a general consideration that itraconazole is considered here because of its effect on both the single and multi-cell fungi. Supportive treatment, I feel like I may not have to go through this in detail thanks to everything you guys have done so far. Limbic system retraining, there's such a significant nervous system activation that occurs with these folks, especially if there's CNS involvement, that we need to correct for this. And this might even go before, just like Dr. Farrow kind of outlined her hierarchy. If folks aren't getting well, or we recognize this to be a significant enough of a burden, there's a tremendous amount of utility to mindfulness, which we've gone over in a few different ways through this weekend. This is beyond mindfulness. This is retraining. For anyone that's old enough to kind of appreciate the operator switchboards, right? All of the wires are crossed. The system is dysfunctional. It's not enough to just tone it down. We have to repattern the system, and there's various means, and primal trust and journal sharing and all kinds of stuff. Biofilm disruptors are very important. This is why, again, I do like the use of herbals or any of the proteolytic enzymes as well that were brought up. Go slow, it can hurt folks. Sweating sauna can be a part of the active treatment, not just the provocation process. Start low, go slow. Supporting bile flow, I'll use a lot of choline, specifically if someone has a SNP related to that. There's a few things very quickly. Half of your methylation power goes towards producing choline and creatine, and we can spare some of that methylation power by way of supplementing when appropriate. Choline is supportive from a neurocognitive perspective, reducing neuroinflammation in addition to what it's doing for bile. And it's just fundamental in terms of cell membrane integrity. And when we get far enough through the treatment plan, that becomes a very significant part of what we need to do. I'll also use a lot of taurine in practice. Not only is it a mitochondrial antioxidant, you're increasing exercise capacity, which is a no-brainer for any of these patients. It's an osmolyte, right? And it's helping to support cell membrane mechanics, cell transporter mechanics by way of regulating those electrochemical gradients. And it helps with bile. Glutathione, again, we kind of talked about how to approach that. And again, we touched on the fact that if we don't adequately address gut epithelial dysfunction or inflammation, we're going to see that anchoring it to the Th2 response, and we're not really going to help manage those symptoms very well. I said to Dr. Ray that he could probably chop this slide up a little bit with respect to the mitochondrial support. I know he'd bump up those doses a little bit with respect to the mitochondrial support, but these are some of the things we want to think about. And just piggybacking on Dr. Cook's comments on mitophagy, autophagy, things like urolithin A, spermidine, Pac-Man, right? Cleanup crew, getting into a position where we're not just supporting the integrity of these systems, but creating a space where they can function better on their own innately. So I know this is a lot. I usually don't have so much information on my slides. It was just, I'm trying to be on time. Do my best, guys. But I just wanted to make sure you could refer back to this. There are some resources on the slides. There's a single-page handout that I've included with respect to some of the additional education you can consider with some of the powerhouses, Jill Krista, Neil Nathan. Dr. Ingalls does a great job of looking at this intersection between mold and Lyme and co-infections, Shoemaker protocol, and some information about testing, air plates, and then the home inspection. Robert Steller is the OG in this field at Steller Environmental. In Simcoe County, I work more closely with an individual by the name of Ian Bleakney, who has a personal story around this and is now doing his training in SIRS and biotoxin illness and able to incorporate that in a more meaningful way into inspections. And mold pros out of the states provide consultations, so keep that in mind, because we remediate the body. They can do the other good stuff. Thank you, guys.